And hi everyone. I'm just looking quickly at who's on right now and recognize many of you. Hope to get to know the rest of you. And I will, like I was telling Marla, Joe, and Sarah earlier, along with the team of us, of course, we put together this, which I think is a great, solid presentation. We should stir some good discussion. Of course, like everything else, like I wish I had an extra week to polish this a little bit more. But let's talk about really just public health messaging in San Diego County, especially as it relates to the work that we all do. And I just want to acknowledge that who is in the space are people from the continuum, if you will, from all the way from the prevention and whether it's county folks or county contracted or nothing to do with the county government folks. We all have a different role, whether it comes to prevention, treatment and harm reduction, and across the continuum of how individuals interact with substances, or hopefully don't interact with substances, and how we approach them and our care of them. So wanted to talk and spend a little bit more time on all this. These are the learning outcomes. I will probably go a little fast because I have quite a bit of slides, and some of them I'm going to go more quickly than others. But if I'm going way too fast, please just put something in the chat or something and tell me to slow down. So, and this will be recorded. So here's just, and as Marla mentioned, I'm the relatively new public health officer. I started in May, but I've been in the county since 2015. And before that, I was in New York City Health Department, which is the largest local health department, where I was working on addiction with tobacco, and I was actually the medical director and overseeing a clinic for New York City government employees treating tobacco. But I also did other efforts, of course, and previous to that, during my residency and during my training, I actually worked for the same bureau that Jared, I see, is on here, worked for, the Bureau of Alcohol, care and treatment, prevent alcohol drug use care and treatment, I think it is. And so where I did a lot of different work on buprenorphine and alcohol mainly. But and I also want to talk about and acknowledge that while I'm talking about substance use in general, I am really talking collectively around not just any particular, and not just whether it's legal or illegal, or based on legal status. I'm talking about really substances in general and how that can drive addiction and a lot of our interactions and exposures to make us more likely to use substances, as I'll talk about in some of the prevention work. So here you see the learning outcomes. I'm not going to read them all to you. And because this is a long presentation, I like to sometimes do the bottom line up front. Dr. Koenig is on here. And others have taught me to really use this as a key strategy sometimes, just to make sure, right, as a communication strategy, what are the key things you want to get across? This is a communications related call. And so I definitely want to talk about some of these. And so the first number one thing, especially in today's age where there's just a lot of difference of opinions and a lot of anger towards other Americans and others, is really just treating people with dignity, just basic, what we learned in kindergarten. And then two is that prevention is critical. We cannot emphasize how important it is for prevention, right? We don't even have to deal with many of the things that we're going to be talking about if we can prevent it in the first place. And so many of you I know are working in the prevention space. I know there's been changes in the prevention space and how things are funded with Prop 1 and things like that. I'm not going to be talking about those specifics, but I know that some of these things are maybe impacting some of this work, or how it's being done. Although on one part of it, and I know there's multiple aspects to this, is that some of the funding and some of the work on prevention is also going to the state, which is going to the state health department. So making, solidifying this as really a public health, what I would consider a core function. And then three, consider a targeted universalism approach. And so just quick raise of hands if anyone has even heard of targeted universalism. It may be newer to a lot of folks, and I probably should be defining it here, but I see Marla and some others. So thank you. But this is the concept where, right, you have a universal goal. So we want zero I'll just say opioids, or let's just say drug overdose deaths in San Diego County. And that is maybe a lofty goal, but that is a universal goal. We want zero drug deaths, and overdose deaths. And so then now, what do we need to do to get there? And so we may need to have targeted approaches for different communities, maybe for Alpine, which has a higher, drug overdose rate than, I don't know, some other parts of the county, or maybe for downtown San Diego, or maybe by race, ethnicity, or by, age distribution, or other things. We may have to have more targeted approaches. But as we're thinking through all this, we should always keep data in mind when we have quality data available to us, and of course, evidence-based practices to drive decision making. Okay. And then just for you all to understand, kind of before I could even talk about some of the public health strategies, I just wanted to explain some of where we're coming from in terms of how we think about public health. And one of the best ways to think about what is public health and what is kind of part of the public health conversation and the views and the stand is to look at our standards. And so we have an accreditation board, and we are accredited health department since 2016. A year after I got here, I know we got our accreditation, and then we re-accredited recently, I believe in 2023. And so but as you see here on the top is the foundational areas of what our accrediting board at the national level, considers as foundational to public health. And that's communicable disease control, chronic disease, and injury prevention. And many of the overdose prevention falls into that area, the injury prevention, environmental public health, maternal, child, and family health, which I would argue includes a lot of the prevention work, and then access to and linkage with clinical care, which also talks, and addresses some of the treatment and the harm reduction and other efforts that many of you are involved in. So, and then on the bottom here, you see foundational capabilities. So you see 8 different capabilities: assessment and surveillance, policies development and support, community partnership development, accountability, performance management, equity, which was only added actually a couple of years ago in 2022, emergency preparedness and response, organizational competencies, and communications. You could tie all of those 8 foundational capabilities to work that we are doing as a broader coalition when we are looking at substance use, whether it's prevention or treatment. And so many of the things that we're doing, right? We for example, we stood up in partnership with behavioral health, with EMS, with the medical examiner, an assessment and surveillance arm, what's called OSAR, or the overdose surveillance and response team. So and I could name examples for all of these different things. And so we are trying to look at this comprehensively, and we are trying to continue to look at this as a public health issue that we know it is and continues to be. And when I say public health, I am in no way saying that this belongs 100% to the public health services department. I think of public health broadly, and many of you have heard me say this, that public health is a team sport. And so we need each other. We need to continue working together to prevent, promote, and protect. And these are kind of some of the 3 things that we often say that, ways that we can kind of simplify, maybe oversimplify the work that we're doing, but ultimately this is what we're trying to do to improve the community's health outcomes. Okay. So what are we seeing? So let me ask you all first, right? What has been changing in recent years that we probably need to think through in terms of, the world in which we're living in, the way that people respond to health and public health interventions? Anyone want to be bold and raise their hand or put in the chat? Let's see if I can even see the chat. Yes, Lisa. Hey, Lisa.
I would just say, good morning, or is it the afternoon? Good morning. Just the media and how we receive our news and the different ways that people get information now versus 5 years ago, and how that's influencing and putting on the
right.
chopping block public health and what that is.
Yeah, and then there, of course, yeah, there's a lot of questions around funding, or do we need as many folks in public health, et cetera. And just this weekend, you may have seen that there was a reduction in force, but then about half of them were brought back, thankfully. Any other thoughts?
Well, there's a lot in chat, Dr. Sayone.
Oh, I'm sorry, I didn't see
A
the
lot
chat.
of mental health issues, somebody said, an epidemic of misinformation, normalization of marijuana. Um,
Yeah,
um, Joe said that youth rates are going down for alcohol, tobacco, and cannabis, according to a few different studies, including the ABC study. So,
yeah. Thank you. Okay, thank you, Marla, for highlighting that, and appreciate if you could continue to highlight anything in the chat, just because for some reason
absolutely.
it's not showing on my screen. Um, and thank you all. Those are all correct. I didn't even highlight those in here it is. Some of the things that just a few of the things in terms of things that we're seeing, and this is the new normal, if you will, in terms of what we're dealing with in terms of public health efforts and work. And so there's also, like Lisa mentioned, changes in terms of how we receive information and communications. There's more isolation of people, right? Whether it's because many of us can remote work, and so we're less social and not, having the daily interactions that we might have had a couple of years ago, or which may be convenient for other reasons, but contribute more to isolation. But then also just more isolation in general, as especially as we age. There's also use of social media and many other things, right? So, but I think the point of this is just to say that our strategies have to keep evolving as the times are evolving, right? Whether we agree or not, this is just the realities that we deal with, and then also that we need to rely and over rely or increasingly rely on trusted messengers. And those are many of you, right? Because if there is growing trust, whether it's different communities, and some communities have historically had reasons not to trust, for example, us government for various things, and then now I know there's other reasons, and so then we have to go through the trusted messengers to get the message across. So continue to think about, like, who are the quote unquote influencers, and whether that's in person or whether that's TikTok influencers or YouTube influencers, right? In terms of how do we get the message across? So before talking about, or wanted to talk about some focus areas before talking about some messaging strategies, and just show you that at least at the county level, we do have some alignment that I wanted to share in terms of what our messaging is and our strategies are. So here you see in front of you that our Public Health Services Department strategic plan, and many of you may know this, we are part of a broader integrated health and human services agency with many other sister departments. So we're at the bottom here, you see workforce development, community partnership, and equity and access to linkage to care. And then you see at the agency level, the strategy is aligned. And then at the county level at the top, there's alignment. So just wanted to show you that, across county government, and we are a pretty large government, and we do have the fifth most largest population of any county in the country, so that does make some sense, so that we are aligned, and it is important that we not just be aligned internally within government, but as much as possible, as we're all kind of tackling these topics. And so and here's three focus areas I just wanted to talk about. And we wanted to talk about building trust, and looking at these areas in these. And so wanted to talk about, building trust, sorry, and with stories, empowering communities, and then engaging communities, especially around the how and the who, and then also looking at equity. And you could, there's different terms, and even these days, I know equity could be a little bit polarizing. So, you could just use fairness, is really the concept we're trying to get through. So use whatever resonates with your audience, of course, and through but we want to do contextual messaging and sharing, because that is important, that we look at all these different where there's differences in the data and try to account and try to help so that there are less differences with what we're seeing in the data in terms of negative outcomes. So in terms of trust, going back to our roots as human beings before we had pen and paper, right? And or maybe when we started to, right? We would we were storytellers, and we know it continues to be really important as we evolve and as we influence other folks. So one thing I wanted to highlight is that many of you, especially on the treatment side, or the harm reduction treatment and or harm reduction side, know, and even the prevention side, know the value of lived experience. And so we talk about that and the value of people who've gone through things and can share those stories with other people to influence them, hopefully positively, right? Whether you're at an AA meeting or an NA meeting or you know, helping, you know, talk to teenagers about why maybe it's not a good idea to start something, or having, you know, being equipped so that when their friends ask them about something, so they know how to respond, so they're prepared with a plan. You know, that lived experience, those stories are meaningful and they go a long way. And so, you know, that continues to be the case. And I know I'm not starting with the story because I'm talking to you all about strategizing, but when you are talking to your intended audiences, please consider bringing and, you know, starting really with stories because they help center the conversation. As does someone with lived experience, if you have access to those individuals. And then many of us have lived professional experience, even if we don't have lived experience, and some of us have both. And it's good to acknowledge and appreciate all of those. And so there is growing data on really stories connecting us, and even you'll see if you can, I'll share a PDF of these slides and you can click on these later. But there's stories like this NPR story that's linked at the bottom, highlighting a study that's showing that, you know, when they've done studies, and this was a Princeton University study, I believe, where they recorded the brain activity of different people. And as the person who's listening, as they have more comprehension or listening comprehension, their brain waves are actually starting to synchronize with the person who's telling the story. And that synchronicity is really what helps us capture, right, the meaning, the situation, the context of what we need to do, and hopefully connect us more so that way we can get across what we need to and have a more emotional attachment and a reason to follow up on whatever it is, right, we're trying to affect in terms of behavior change or prevention, et cetera. So it is really important that we operate in one way that is very helpful is stories. These are, I'm not going to dwell on this, but these are some examples of, we all remember, you know, in the very early days of COVID, I was in the emergency operations center with some of you, but I know, you know, many of us watched and looked at things like social media, where we saw what you see on the left side of all of these dual images. And then you could see how their stories evolved over time in positive ways, you know, after dealing with the isolation or, you know, delivering in a mask and things like that, and, you know, things that just were difficult at that time. Now moving on to community engagement, I wanted to talk about, you know, how we engage the community, and that words do matter, and how, you know, and the approach that we take, of course, it matters. And many of you know this, and many of you do this day in, day out. So I know this is like common knowledge for those of you on the ground, but I just wanted to highlight that there is research to support this, right? There was a the Beaumont Foundation had a research, and they, I think, and that's what's linked below on this communicating about public health toolkit. But they talk about things like, you know, using words that resonate these days versus avoiding or being cautious around certain words, because they can be off-putting or they can make it more difficult to understand what you're trying to get across. And so know your audience. Like I just mentioned earlier, you know, knowing the equity sometimes in some groups, you know, maybe polarizing, that's okay. You know, just avoid it. Your goal is not to say one word in particular. Your goal is to get across the concept that you're trying to get across, so that people can ultimately change their behaviors and for positive, in a positive direction. So these are some examples, right? Using words like communities, safe. Public health professionals like to work to keep community members safe, protect everyone. Public health supports everyone, equal chance, things like that. And then words not to dwell on. And I just wanted to pause here before sharing a wonderful resource with you all, just to ask you, what are other words that you could think of that we should be using with caution? And what are some words that resonate?
Dr. T, I'm looking at chat, so if anybody puts anything in chat, I'll be happy to read it.
I think I finally figured out how to look at the chat. Thank you.
Okay, I don't see anything coming in.
Well, that's okay. Normally I'd wait and okay, I see caution equals CDC community member versus target population. Yeah, thank you, Dom. And I love that we have this resource that is on our SUOP website. And thanks to, I know, Marla, Sarah, I'm sure Joe, and many others who contribute to this for making this. This is the second page of a two-pager that's linked on the bottom, the Words Matter handout. And I really like this one just because, right, we know then going back to my kind of number one takeaway, right, treat people with dignity. Some people who've gone through treatment and you know have that lived experience may actually use the voids that I'm recommending we avoid, and you know that's okay because that's just what you know the culture, the words, the terminology has also kind of continues to evolve, and so it, you know some people may use these, but as much as possible you want to try to use the words that is on the right side of this, just because it is less judgmental. It you know it implies that you're coming at things from a different space, and goes back to treating people with dignity, and then people are more receptive, right? If you have to think about what is the end goal here, right? Is it that you want to use certain words, or you want to get people to change their behaviors? And I know I keep harping on that, but that is really the justification. And as much as we can, if we could reduce the stigma, then we can get more people in, you know, in services and treatment, you know, and things like that, and to accept things, because we know, for example, just that our own local data, that about 1 out of 10 San Diegans with a substance use disorder are actively, you know, or are seeking treatment or have sought treatment on that. And someone feel free to correct that statistic if I got that wrong, but it is a really, really low number, right? Like if I told you 1 out of 10 diabetics, you know, were in treatment for diabetes, that would be shocking. We would, like, you know, call like all of our medical organizations together and think about, okay, what are we doing that we're missing 90% of the population with diabetes? And so, and we would not put up with that. And I'm not saying that we are, because I think collectively all of us are on this call because we agree that, you know, people need more access, and but we also know that to get people to accept treatment, that we have to continue reducing the stigma, make it easier to access things, and deal with other things like that. So this is also in terms of community engagement, talking about the accessibility and really connections and strengthening our connections. So you know, and really learning to connect beyond your bubble, as I like to say. And so, you know, how do you approach people? How do you lay a foundation? How do you strengthen that connection? How do you use words that are helpful in that scenario? And so these are some tips. I don't have to go through all of them, but just as some example, right? Like appeal to shared values. What do we have? We actually have a lot more in common than we sometimes recognize. You know, DNA wise, over 95% of our DNA is in common, believe it or not, across the globe, right? But we tend to focus on, just using that nerdy DNA example, we tend to focus on the 5%, right? Or even less, I think, that is not in common sometimes. And so but same thing, you know, we want to lay a foundation, create that mutual understanding, be inclusive, keep the conversation focused, and then use familiar phrases, like I said earlier, right? Paint a story, use stories, paint a picture, sorry, with vivid words, and use phrases that are accepting from your targeted audience. And maybe I should say targeted, to given one of the chat comments. So, but we know that when the work gets harder, it's more important to become strategic. So, if resources are less, and yes, someone acknowledged that at the federal level, there are some kind of cuts to public health. I will say also at the state and local level, we're dealing with, budget issues on both fronts. And so that's impacting us too. And that will continue to impact us, right? So there are many different things that, of course, are impacting our dynamics locally, at the state level, and federally. So we need to be focused, and we need to be more strategic. And this is when you think about things in the policy systems and environmental change aspect as well, right? And so this is now talking about equity through context, thinking about the cultural mindsets, and really how do we frame disparities or health disparities in terms of past, present, and the future, right? And so to open people's minds to promoting health, and especially in marginalized communities, right? When you're talking about, again, a rural community or a certain race, ethnicity, or age demographic, or whoever you're trying to get to, if there is a health disparity, it is important to think through differently. And if you are meeting with a group that represents maybe one group, that represents one of the disparate groups, it is important to think through, okay, what approach works, to speak to the history, to acknowledge what's already been happened, to give examples and historical policies that may help to explain kind of the health disparities and why we're here today, but then move to the present and future, and what can we do to move forward, and what can we do collectively to address it, right? Not just talk about the past, but we should acknowledge the past so that we have a acknowledged mutual understanding, and that we're not just coming in with recommendations for the future, but we're acknowledging we're working together towards solutions. And these are just kind of generic and not necessarily dependent on any content area, but just good thoughts to do. And so this is also, kind of like I said earlier about things to say and maybe words to avoid. These are also different types of mindsets to that are more productive than others, right? So if you have these mindsets around contextualism and shared faiths and efficacy, that's often more helpful in discussions than things like fatalism, than that and otherism and individualism, because then you're moving groups of people in a positive direction and showing that you're unified in your approach. And then just wanted to share some data around our regional messaging, but let me just check the chat for a second. Caution smoker, yeah. Rather use someone that smokes, yeah. And that's a good point, Lisa. Yeah, that's called people first language. People may have heard about that. So and we use that across, and it's not just a health thing, but like you could say people experiencing homelessness versus homeless, because people aren't defined by their status, the housing status, right? There's much more to someone than their housing status, for example. And the same thing here, they're not just defined by their smoking status. And instead you want to start with the people first. So a person that smokes. And then what I wanted to share is some data. Many of you may know that we have community health assessments, and community health improvement plans. And so based on those that we conduct at the regional level, and in each of our kind of 6 HSA regions that many of you may be familiar with, the groups and their community leadership teams, have are co-chaired not just by county staff, but also by community members. And these are many of you or your peers who are kind of CBOs or people actively engaged in the community and who know that community. And so so we at each region, we want to also be more specific, since we are such a large county, not just in terms of population, but in terms of geography, right? So like the health priorities in one part of the county, northern county, may be totally different than, I don't know, the east part of our county or the south part. And so you see here in front of you the top 3 priorities by region. And there is some overlap, and you see that on the top, the housing and homelessness, behavioral health, and economic and food insecurity. For this conversation, and wanted to highlight, wherever we see behavioral health, usually that's inclusive of mental health and substance use. So the unless it's called out separately, but where you see like on the bottom right, substance abuse, which is one of the words not to use that we recommend. I'll talk to my people about that. So, and then before getting into a couple of things, wanted to share. Oh, I'm sorry, I think this slide is out of order. This was the slide I meant to go to next, is that the community health assessments, you saw that there's a lot of observations related to, amongst behavioral health conditions, specifically like alcohol use. Dependency was a top cause for ED discharge, and hospitalization rates and drug overdoses was the leading cause of death rate. It was, all drug overdoses were part of the leading causes of death when we looked at San Diego residents. And so there is a unintentional deaths category, and that is in the top 5. There's many other things outside of drug deaths that contribute to that, but this is a significant part of that category, if you will. So, and then, sorry, just wanted to go back to before talking about messaging strategies, just one thing just for context is that as a county, things have been changing locally here too. And so just highlighting, sorry, one second. That in 2021, our board of supervisors, and as you probably know, we have 5 elected board of supervisors. Technically, they're non-political or partisan, but we all know that's hard to operationalize. But but our board of supervisors in 2021 did develop a comprehensive harm reduction strategy, and that includes, as you see here, collaboration, housing, workforce, healthcare integration and access, and then we have a ongoing kind of effort and need for this that I'll talk about. So continue to strengthen partners. This is just one example. The other big example of this example, sorry, is our Live Well San Diego vision. As you know, this is a vision for the whole region. Even though the county staff are the backbone of this is not just county. This is really everyone and all of us, and it takes all of us, right, to build better health, live safely and thriving. So this is a vision and a model that we have here that facilitates collaboration that most other counties don't have. And so one theme that you see across San Diego is that we are very collaborative in many different respects, whether it comes to on the healthcare front, on things like SUOP, Substance Use and Overdose Prevention Task Force, right? It brings together coalitions, or we like to build coalitions, the obesity initiative, et cetera. It's the childhood obesity initiative. There's several different examples where we are very, very collaborative. And many partners, like just last week, I actually left the SUOP executive team meeting just to go talk to 2 other counties in Southern California who wanted to learn about our Live Well San Diego vision and how we operationalize this. Many of you see in my background, I talk about the advance. And so that is another opportunity to bring partners together to learn from each other. And thank you, I see Joe put in the chat, learn from each other and share information. And then this is just one example. During COVID, we continue to do communication strategies, which we really leaned into during COVID, but it's not only specific to COVID by any means, where we do telebriefings, e-newsletters, sector specific web pages, resources. So please, if you are not already using the Live Well kind of framework or the vision to take advantage to do more communication or be in those spaces, please consider it, because there are different ways to get the word across. And you see here, we have over 600 recognized partners across multiple different types of sectors, from business to cities and government to CBOs and faith-based and schools and education. And I love this Stephen Stosny quote: "If you want behavior change from a partner, child, relative, or friend, first show value for the person. If you want resistance, criticize." So I say that because, going back again to stories and how we ultimately what we want, whether it's substance use or prevention or treatment, or if it's things like eating healthier. You see, a nice array of fruits, colorful fruits and vegetables in front of you, or we all know that a lot of this is not rocket science. We actually have a lot of the solutions we know that we need to live and lead healthy lives. And so we know that stories are meaningful, but we know also the way that we approach people and can lead to stigmatization or can be inviting for people to accept or even talk about things and be willing to talk more. So and just again, please utilize the Live Well platform if you're not already. And then the other one is SUOPT, and we have a lot of others. We also have, the underage binge and underage drinking group. We have the marijuana prevention initiative. We have a lot of different coalitions and that we need to continue to lean on. And then we can also do, cross messaging, because some things are interdependent, unfortunately, and people don't just use one substance at a time. And so, sometimes it is important to step back and see, are we threading even across our own coalitions around substance use and other efforts. So now I'm just going to finish off just by talking about messaging a little bit. I see I'm already at 11:38, so I'll be very quick. And again, this is just an overview. Many of you may have heard of like the concept of primary prevention, secondary and tertiary prevention. This is a public health way of approaching prevention. And so primary is really like before anything even starts, you want to do upstream things to contribute to and decrease the likelihood that people even start, for example, substance use. And then secondary is to reduce the impact once it's already occurred. And tertiary is really if people just continue to use, okay, what do you do to, reduce those negative consequences? And that's where harm reduction really comes into play. But we all know, and I will emphasize this over and over again, this will be on my grave, my tombstone, prevention is better than the cure, right? Like, and it is hard to hard not to emphasize this, because we know that we don't even have to deal with the things that we deal with. We know that when people get addicted, the way the addiction works, it rewires your brain. Oh, this slide did not come out. Oh, I'm sorry. So, and then we know in terms of prevention, we know what generally the risks are. We know that people can have none of these risk factors and still fall to addiction, but we know that these types of risk factors do increase the likelihood of risk for substance use. And so what can we do about it? Conveniently, the CDC just came out, and someone who lives in our backyard who presented to our substance use overdose prevention healthcare task force on Friday and the executive committee last week, Doug Roller, he no longer works at CDC. He now works at for the state marijuana prevention group, I believe. And so he and his team put together this evidence-based strategies to prevent youth substance use and overdose. And so these are the protective factors. This is the things that we need to bolster up. And many people don't realize the link between some of these efforts and ultimately the value it has and the influence it has on preventing people using substances, or if they use, to become addicted and and chronic use over time. So but that is things like enhancing knowledge and skills, nurturing family environments, giving access to resources and activities, amplifying protective community environments, guide efforts to lessen immediate and long-term harms, and encourage provider and health system engagement. So many of us, we all have our different stories. I was a athlete. I did choir, other stuff, but I was an athlete and a track in high school. And so when people would ask me if I wanted to smoke a cigarette or weed or anything, I was always like, no, I got to stay on top of my game. That was my prevention message. That was my excuse, so to speak, at least for that at that time. So and so we have to give people the tools and right and that goes back to giving people other positive kind of quote unquote distractions, so that, or habits and things to do, so that people are supervised and things like that. We know we have strategies. I'm just in limited time, I'm going to skip over some of this. We know we have strategies on talking to youth. We know we have resources for talking to youth, for parents, for community. We many of you have participated, and BHS has sponsored or paid for through our contractor, putting out ads against and awareness campaigns in places that people actually might see it, like Twitch, which is a gaming platform, and things like that, or Facebook and Instagram, because of the way that people receive information. These are I think maybe now a couple of years old, and billboards. But ultimately, we can do all the prevention that we want to do, but we know that some people, some segment of our population will will fall into what's called addiction or chaotic substance use disorder. And that is a chronic relapsing disease. And that is where medically and from a conceptual perspective, even though it's part of that continuum, we have to reframe and think about how we're thinking about people in these, after that, once they're regular or are using substances regularly. And so this is a chronic relapsing disease. Like I said, it rewires your brain, right? It changes you, and there's a whole bunch I can get into about dopamine and how this impacts your brain. But I love this quote: "Addiction is like driving a car without brakes. No matter how much you want to stop, you will not be able to do it." And this is from our National Institute of Drug Abuse director, NIDA director, Dr. Nora Volkow. And so it was a wonderful quote because it really talks to, how difficult it is to overcome addiction. And it really is, quote unquote, act of Congress, right? For many people who many people with lived experience, and how hard it has been. And what I think a lot of people that I talk to don't necessarily realize is that relapse, is a part of it, getting over addiction, just like it is a part of many other medical conditions. So when we talk about substance use disorders, often people talk about the illicit or illegal substances, but for smoking, there's a lot of high rate of relapse. For alcohol, there's a high rate of relapse. For blood pressure and asthma, there's even relapse rates, right? As you see here, these data are older, from 2000, but and I need to look for a newer version of this, but this was on NIDA's website, and so I took it off there. But it is just important to know that, like, when we should conceptualize and think of these things, in and with respect to many of the other ways that we conceptualize other things in medicine, so that we're not singling substance use out, so we're not sensationalizing or treating it differently, which then contributes to stigma. We need to understand, and many of you do, that because it's a chronic relapsing disease, that relapse is a part of people getting to success, whatever that success means for them. So we know from a messaging perspective, bottom line, call access and crisis line 988. And we know we have naloxone distribution. We know we have, thankfully, I put in the bottom, SUOP created an interactive MAT and naloxone resource map. So we have kind of key messages that you can point people to where to seek treatment. And then I just the last few slides, I know I'm way over time, I'm sorry, is just that, for treatment for opioid use disorder is just one example. I know we also have alcohol and other things that we deal with, is that, that we, for some things, for some of these substances, we do have very effective medications, and we cannot lose sight of that too. It's, again, going back to the diabetes example or something like that. If I was to have wonderful diabetes medications, which we do, ideally people would prevent diabetes. When we see people in pre-diabetes conditions, we would do things and take extra additional efforts to prevent people from becoming diabetic, for example. But once people are diabetic, we don't want to withhold, the evidence-based medications that are helpful for people with those conditions. And so we have the same for medications for opioid use disorder, and we shouldn't forget about that. And while people, one thing to note is that buprenorphine, for example, that curbs cravings and decreases effects of withdrawal while also blocking the opioid receptors, so that additional opioids will not have effects. So meaning if you take it for pleasure, illicit substances that wouldn't have an impact. And so this is helpful. And then because it rewires your drug use, rewires and addiction, rewires your brain, this can over time provide a level of clarity, at least enough so that people are willing to engage. And that's what we see in the data. This is clear in the data that when you use medications for opioid use disorder, you have decreased overdose death, you have increased retention in treatment. So if the goal again is to get people to quit or to reduce their use, or reduce their chaotic use, with the ultimately hopeful goal of quitting, but we know that doesn't work for everyone. But this helps you retain people in treatment. This decreases illicit use and other criminal activity, increased ability to gain and maintain employment, right? Productive members of society, improve birth outcomes, decrease infection rates of Hep C and hospital visits for skin infections. So, all I see in front of me is good news, right? And so these are more reasons why we should be promoting these evidence-based medication, just like we promote blood pressure medications for people with high blood pressure, diabetes meds, et cetera. But just speaking of harm reduction for the few minutes that I have, that of course we know along the continuum that some people, may not be willing to engage in treatment to quit with the ultimate goal of quitting. And so this is where it's most important. I think along the whole continuum, it's incredibly important to treat people with dignity and meet people where they're at. But this is where it's most important, arguably, to meet people where they're at, just to acknowledge their reality, their lived experience, and provide the support that they need, right, to even help each other stay alive, whether it's naloxone, whether it's syringe services, things that are evidence-based, that are going to help them keep alive and keep them from getting new infections, et cetera, things like that. So I don't see these things as when people talk about treatment versus harm reduction, it's an and, right? It's different approaches for different people, depending on where you are on the continuum. And we know that more people who are engaged in harm reduction are more open to and just like opioid use disorder, the meds for opioid use disorder, they're more likely to engage in treatment and maybe consider quitting down the line. So but ultimately we're just doing what we do in the rest of medicine. If someone comes to me with diabetes, I'm not judging them necessarily, or not treating them because they're, I don't know, eating too many donuts or something. I'm just making something up, but I'm going to continue to treat them because that's my role. And so this is just an example. We're short on time of one of our harm reduction services program that we have and operate out of Rosecrans with our Live Well on Wheels bus, and some of the outcomes, but we do serve a lot of people who are experiencing homelessness. We do do a lot of testing for HIV and Hep C, and we do have folks see over here, just within a year, 517 overdose reversals were reported to us from the people who got more naloxone from us, and other services like sterile syringes and test strips and things like that. So here's information. And then lastly, I just wanted to close it with two things. One is that I know there's a lot that I could have talked about and probably other things that maybe I should have, but really I love, again, this quote from the head of NIDA, Dr. Nora, the great tragedy of the opioid crisis, and you could apply this to many of the other crises, right? It's not specific to opioids, is that so many effective tools already exist but are not being deployed effectively in communities that need them. And so from my perspective, I think, are we doing as much and as strategically the evidence-based things we need to do on the prevention side? And then once people are and become addicted, are we doing as much as we need to do, and as strategically, in terms of the treatment and harm reduction side? So we need to continue, again, back to key takeaways: treat people with dignity, prevention is critical, and consider a targeted universalism approach, and using data-driven and evidence-based practices to drive decision making.